Hello and welcome to Research Matters, the podcast where we discuss research matters, why they matter. My name is Joshua Davis with the Office of Research at Kennesaw State University. Today we are discussing how a research team at KSU is developing an AI system that allows a local police department to respond to mental health calls more efficiently. The project, which is led by KSU researchers Monica Nandan, Dominic Thomas, and Hafiz Khan, allows the Cobb County Police and Fire Departments to sift through tens of thousands of mental health calls and prioritizes the department's response, ensuring people are getting the help they need. We are joined today by Monica Nandan, Dominic Thomas, as well as Matthew Dames, a licensed professional counselor from Highlands Rivers Behavioral Health, and Cobb County Police Officer Jacob King. Good to see you. I guess thank you everyone for joining us today. Just so we can be all on the same page, can you take us through an example? Like a phone call happens, someone saying, I'm in crisis. Can you take us from there, Officer King?
So something typically is, you've got a family member that calls and says that they've got a loved one that has some sort of psychiatric disorder. We go out and our initial decision point is this person an immediate threat to self or others? Right? That's the clinical criteria that Mr. Dames has to establish and to be able to articulate to say, this person needs to be removed from the community. That's that process where a licensed professional said, look, this person cannot be safely left in the community. They'll hurt themselves or they'll hurt someone else. And so once that decision's made, then my role as the law enforcement officer is to enforce that and to remove that individual, and then we figure out, all right, are we going to take them to the emergency room? Are we going to take them to the crisis center? Where are we going to transport them for that period of observation?
So this phone call comes in to 911 or 988. Who does it go to first?
So if it comes to 911, the immediate dispatch is going to be to whatever units are covering that precinct. So we have 5 precincts in Cobb. So depending upon where it's located, it'll be dispatched to the officers in that precinct.
Okay.
As they go out, one of a couple of things happens. Either we'll see the call pending and we'll self-dispatch and say, hey, we need to address this. We need to be out there. Or we'll get a request from the officers on the scene and they'll say, hey, we need CIT support. We need you to come out here and talk to this individual.
So when did Matt come in?
Yeah, so we got started in July of 2019. That's when I kicked it off. And had some initial, good success. The outcomes were good, but the problem was with crisis calls in particular, it was taking 5 and 6 hours to process them. And so when you've got one person handling all of that demand,
it was just you?
Yeah, it was just me. And so me being out of service, one crisis call and my entire shift was eaten up.
Wow. And
so we were engaged with a community meeting at the time on the topic of crisis intervention, and that got us in connection with what is Highland Rivers now, but was Cobb Community Services Board at the time. Their CEO, Foster Norman, came up with the idea and said, well, what if we put a licensed clinician with you? And then that's where we went down that road to what's now commonly known as co-response.
So what was the moment like with you and Matt having a conversation where you're like, there's just no way we can keep up?
Oh, I think that was almost like minute one. Like
trying to
It's innately obvious.
Trying to figure out where the calls were and how to get them. It was a flood basically of trying to shift through all that data and find those calls, and especially. We've been doing this for about almost 5 years now, and there is better referral process because we've established relationships with beat officers. They know us now. They know that what we do, we can come out and we can help. So they're starting to send it now, but that's only a few of them, and there's still, new recruits don't know us just yet.
So you have new people all the time.
All the time. Exactly. And empty positions.
And empty positions, people retire. There's incidences even now where we find out bad stuff had happened, and apparently this has been a known issue by that precinct for, a couple of years, and we've never gotten an email or even a phone call saying, hey, you guys should come and look at this person.
So when you were doing this in 2020, there were 2 of you?
Yeah, just he and I.
For all of Cobb County?
Yep.
Okay, so this makes sense now why you probably started to speak with Monica and Dominic. So let's talk about the problem that you realized that you needed something else.
So most of the time in these crisis calls, they don't need somebody to come out right now, right? And so we have, we've been training our officers for several years. Hey, do an incident report, send me an email, and we will go out, because a big part of what we're doing is following up with individuals post-crisis or in best case scenario before a crisis happens, right?
Okay.
Trying to connect them to services. So where the gap comes in is that to get those referrals, I'm dependent upon the officers to go out, do an incident report, and send me the information so that I know that, hey, here's an individual in the community that we need to go out, us or one of our teams needs to go out and talk with that individual. So what KSU has talked about is using and leveraging AI. And I'll be completely honest, I'm not a tech guy, so they're going to have to answer the tech stuff.
No, that's perfect.
But leveraging that to search through our incident reports and look for ones that are likely need our attention, that are related to mental health and behavioral health concerns, so that instead of me having to go through, I think we write roughly 150,000 incident reports as an agency every year.
Sure.
Instead of me having to go through that volume of incident reports looking for the ones I need, and an AI program can scan through that, get rid of all the background noise, and then just send to me the ones that I need to review to say, okay, yes, this is within our wheelhouse. We need to deal with it.
Okay. And then I guess, Monica, so the connection between these two. Yeah, share.
So it was probably 2017, 2018. Dominic and I were invited to attend a meeting where Cobb Fire and Cobb Police came to us, along with public health, saying we're experiencing, Cobb Fire and Cobb Police was experiencing many 911 related calls that were coming to them related to social health and behavioral health. And they came to us looking for MSW students to do internships with Officer King. We met in Pullman Hall. We said, tell us the volume of this problem. How many people are calling 911 with mental health? And what are the types of problems that community residents call in with, so that we can prepare our students accordingly? So we did a lot of digging, Dominic and I, and realized this is a wicked problem.
So you guys realized you couldn't handle the load. You needed some help sifting the needles in the haystack, right? Is that a safe statement, Dominic? Is that sort of what
Absolutely.
The okay. So how did the relationship start? The conversation start around that with you guys at KSU?
Actually, I think KSU, Dr. Nandan kind of introduced us to Dominic and his team and talked about some of the other research that they had done, and they were the ones that kind of conceptualized it and then came through. I know through an MOU that we provided them with some old incident reports to go through, so they could build the program and train it, and then we kind of assisted with a glossary or search terms for the AI to start learning from, to the various medications, terminology associated with mental health, so that that program, I guess, for lack of a better term, and correct me if I'm wrong, has a language to start with, to look at, to scan through, and to look for. And so that was kind of all on theirs. We just kind of provided the concept of, hey, what are these terms? What is this terminology that should fit in, and how can we use that operationally?
Yeah, you were giving it the vernacular, so he knew what flags to raise awareness. So, Dominic, can you kind of share the software? What does it do that changes their job?
We've had several iterations of the software. I just came from a meeting with two of the PhD students working on it right now back at my office. So there are several versions of software, and the earliest software, we ran calculations to try to figure out how many of these cases there are.
Just quantity, just getting load to see.
Just quantities. And we were seeing about 11,000 a year of mental health crisis. And then if you expand that to social and behavioral, more like 32 to 33,000. And if we can't measure it, we can't manage it. Basic principle in management theory. So now if we can know some numbers, we have a lot of partners involved in this project. Wellstar has been involved. They don't want these cases coming through their ER necessarily. Yeah. They organize their services to meet the need, but if they can't see the need, they can't organize their services.
Well, and they can't scale up either,
right,
as they see the need. Okay,
That's right.
So you accomplished initially measuring.
Measuring, right.
Okay, so once you measured, then what was the next step?
Well, now we're trying to get much better at typifying the cases so that the needles are cleaner and easier to deal with in the haystack.
Okay.
There are different kinds of cases. So Monica didn't mention this, but she's been involved with Georgia's opioid task force for a number of years, more than 10 years. And some of these cases are drug related. And drug is not always mental health, but maybe 85% of the time there's a
lot of overlap. Yeah.
a lot of overlap.
Well,
so
that's a good point. I hadn't thought about it, but crime isn't necessarily
the only
right. It's associated with other factors.
Mm-hmm.
Yes. And you could have a kid with some kind of autism who just sees something shiny in a car and just gets excited, but the community doesn't know how to deal with that.
Mm-hmm.
And so this could end up poorly. You could have someone who's neurodiverse who just does not behave the way people expect.
That's not a hypothetical. We've dealt with that.
Mm-hmm.
And that's why in jails are the second largest mental health institutions in the country today. 60 to 80% of the people in jails, not prisons, jails, are people with what I call dual diagnosis, meaning having a mental health diagnosis and a substance use disorder.
Well, it becomes a dumping ground, and this is one of the reasons where this program kind of came into existence, is because when we look back historically at law enforcement and the, dealing with when you shut the mental health hospitals down and they said, hey, we're going to build an outpatient network, right? That never really was up to snuff. These people were put back in the community and they're put on a collision course with law enforcement, who up until a few decades ago, when you have the CIT training that comes out, our job was to arrest people. That's what we did.
Yeah.
We see a crime, we arrest them, we take them to jail, right? So that evolves, and then what happens is, as we're dealing with more mental health crisis, our options are, well, if we can talk them into going to the hospital, we will. And if not, if I've got a crime, then we arrest them and we send them to jail. But what I've seen from our data is that the vast majority of the crimes these people with mental health concerns are committing are public order in nature. Right? Mm-hmm. They're not committing murders. They're not committing armed robberies. They're, nuisance behavior that is criminalized. Yes.
Sure.
Some theft, some property crimes. Right. So these become things that wind up being dumped into county jails, because even at the disposition of the case, they're not going to get 5 years in prison for, shoplifting and some of these other stuff.
Right. So, and I guess if you describe the word success, it's getting ahead, doing intervention before it leads to some of these more catastrophic outcomes.
Right.
Can I give a little background to that, just to think about this from a society standpoint? I'm in a business school. One of the projects we did was to try to analyze, we got data on how many pieces of equipment and how many people were coming out to these mental health crisis calls. And now it's not perfect, but our estimate is that each call is costing $500 to $5,000.
Sure.
So if they can come out and keep this guy from being a source of 2 or 3 calls a month, and it's just one visit where they spend 30 minutes or something, this is saving a ton of resources.
And that money we're talking about is a fire truck, ambulance, all the police officers, and all of those staff salaries
and the liability insurance.
So what's your vision of what does it look like? What are they sitting in front of, typing into, to then get these answers they're seeking?
Well, they don't necessarily have to type. We're one of the PhD students right now is working on making a really easy data import process that works with the data they already have.
Okay.
And that is a real challenge because, as Jacob mentioned, he's not necessarily a technologist, so it's got to be super easy. And at the police departments, there's not really a person who does this kind of work. So we have to make it so that it doesn't become an extra burden on the police, because they're already taxed out. It's not simple. I want to comment one thing. You asked earlier how we got to this problem. Mm-hmm. And for me personally, I'm an Eagle Scout. My Eagle Scout project in the 1980s was working with 911 systems.
Really?
And I realized at that time, because one of my assistant scoutmasters was an EMT, and he brought the problem to me. He said, we don't have maps of apartment complexes. So they would show up at the front gate, and there might be 26 buildings, and someone's having a heart attack, and that person would die because they couldn't find the right place to get to. And so from a long time back, I realized, boy, you really need good information as a first responder. or you're going to end up, frustrated and hurting.
So at this point, to answer your question slightly differently from a social work angle, where we are today with the solution we are building, we can today not only determine a behavioral health case from a non-behavioral health case with a fair level of accuracy, number one. Number two, we can also put the cases, the behavioral health cases, into 3 to 4 categories, which is where we are training the AI for right now. This case needs an immediate follow-up by Matt Dames yesterday.
Okay.
That's one bucket. So our system will bring those to their attention the moment they come on shift. Second, this needs follow-up, but not immediate. Third is this one probably needs a referral. Please follow up with them and give them resources. And fourth one is leave them in the community, no follow-up required.
Interesting.
We have a clinician, as a matter of fact, an LCSW, who is going through the behavioral health cases. We have 4 years worth of police data, which is unheard of. We have 4 years, and we are now using that police language, the way they write. We can't train them how to write. They write in their typical police way. Right? They may or may not use the words we want.
Right.
That's where Dominic's brilliance comes in. Okay, how do you take that noisy data, number one, accurately put the cases, the incident reports into 2 buckets, number 2. Number 3, now also help sieve the cream that needs the attention yesterday and that needs attention within the next 72 hours for follow-up. Right?
Wow.
So that from 150,000 cases a year, about 1,200 are written a day, approximately, give or take. Those are the stats.
For Cobb County, which is
just for Cobb County.
That's not the whole county. There are 5 911 centers in Cobb County. We're just dealing with
one center.
Just unincorporated Cobb.
Okay, so for you guys, how would you determine what was urgent when you came in the next day? Because like what Monica's describing is, I'm understanding it's something to assist in helping to go through this. Yeah. How did you do it prior?
And so we use this kind of logic when we're processing calls and looking at what we're going to respond to, but we're looking at things like, are weapons involved? Is there an immediate threat? Has there already been violence? I'll be honest, and it's never like one call at a time in this county. Sometimes you look at what's pending and you're like, that one sounds like it's the most severe, or it's the most severe right now, and we're closest. Okay. And we have the highest opportunity, highest chance to get there and intervene on that one. So we start there, and whatever's left, when we get done with that one, we move on to the next one.
And that makes sense. And I guess, Monica, like really in my perception of AI, it's not intuition, but it's getting close to what a human sort of tries to do with a lot of data to make a decision.
So that's what I'm saying.
Yeah, the word close, the word probably, those are important.
Yep.
This has to be designed with people in the loop. So what we're doing, we're pushing the forefront of AI in clinical decision-making for sure. Mm-hmm. We've got professors Hafiz Khan and Yang Pei in computer science and data science. We've got PhD students there. But how you responsibly deploy AI and have an explanation of how it made its decision, because this thing cannot be doing it based on demographic bias. Right. So we've created debiasing algorithms in it. It's a careful process. I see articles where some high schooler, comes up with a solution and the press wants to say it's done, it's complete. I said, no, it's not. That's not a responsible solution yet. So it is taking us a while, but if we're going to do it right, we've got real people involved here, and we need them to be supported. So it is definitely a challenge.
So technology is an enabler. It's not. Mm-hmm. It enhances. And now with you guys doing your job every day, how has it changed your job?
I think what this is going to bring to the table is it's just going to bring a greater level of situational awareness for us. A lot of the day-to-day stuff, like how we interact with people in the community, those things that we do in the community are going to remain unchanged fundamentally, right? Interacting with people, the social aspect of it, the response aspect of it.
Not going to change.
Yeah, those things are pretty...
Well, you're going to do more of it now, right? You spend less time having to decide what to go work on.
Right. And having, basically being able to interact with more of the community. And the other thing it does is that opens up the door for us to look at the commissioners and the politicians involved at the county level and say, look, this is the demand, right? This is where it's at. This is what we're meeting. And these conversations have taken place, because I will say, when I stepped into this realm in 2019 and people would ask me, well, how many mental health calls are there? I don't know.
Yeah.
And I heard every estimate from 8 a year to 800,000 a year, right? And nobody knew.
Yeah.
Because the one place that all of that data is stored is in our dispatch center. And because of some of the quirks and nuances with that program and the way dispatch programs are built and operated, it is not easy data to get there. But it's something that we've started looking at. And I can say, for example, through yesterday, just in unincorporated Cobb for 2025, we're already over 1,732 crisis calls in just a few months. And we've got 3 teams covering Monday through Friday from 6 in the morning until now 8 o'clock at night, trying to meet that demand. And so this past month, putting in a new team, we've increased that, and we've increased that amount of that demand we're handling, but we're still sub 50% of it.
Right.
And so these types of metrics are important when you talk to policymakers, because they don't want to hear, oh, well, this is going to work. They want you to be able to show, hey, this is what the demand is. This is what we're doing with what we've got. And what we're projecting is, if you give me X amount more, then I can pick up this much more.
Can you share a story where you realized that what you two are doing together is so necessary and has so much impact?
Oh, yeah. So I won't use his name, but we had an individual. He's probably still one of the – we started dealing with him in 2019. So he's, kind of one of the original cases we had. I believe bipolar. He was taking medication, but he was mixing it with alcohol, which made him unpredictable at best. He would get in his vehicle and do donuts in his neighbor's lawns. He was very, disruptive. He had access to a crossbow.
How old was he?
I want to say he's
like 50-something.
late 50s, 60s.
Yeah.
When we started dealing with him, he was probably about mid 50s. And so basically, you've got someone that, while they're medication compliant, they're mixing it with alcohol, so the results are horrible. He came on our radar. The local precincts realized, hey, this is somebody we need to deal with, and we started trying to interact with him. Had very limited success early on. The alcohol was just basically ruining any attempt to talk to him. He got arrested probably 6-8 months after we started trying to contact him, and it sounds horrible, but fortunately, one of the charges that he caught when he was being arrested was he made some threats to the officers. Oh. So the misdemeanor charges now had a felony. And what that did is that opened up the mental health court to this man. And so because of that, and because of us being involved and encouraging him to, hey, you need to apply for this, you need to go through, he was able to go through what is typically about a 2-year process in about 18 months, and then graduated. And that was several years ago, and he's been sober for 3 or 4 years. He's been out of that program for probably close to that time frame. Yeah. He's medication compliant, and it is literally a Dr. Jekyll and Mr. Hyde. Yeah. Because the individual I met, like early on, I was concerned several times, hey, he's going to come out of this house with a crossbow. He's going to make me shoot him. That's how unpredictable this guy was. And now he's one of the more pleasant people that, we converse with on a regular basis.
The public mental health field is the safety net for the community. And I've seen that safety net have gaps in that net where people are falling through all the time. And I've seen that they weren't getting the help that they actually did need. And doing this, jumping into the car with Officer King, feel like I'm actually for the first time doing something to help bring the help to these people. Because a lot of the times it was folks just couldn't keep their appointments because they didn't have vehicles. They couldn't get to the bus line. They ran out of meds, and then they relapsed and ended up being back in the hospital because they couldn't get the assistance, or no one was tracking them or keeping an eye on them and going out and saying, hey, we haven't heard from you. At an outpatient site, they might call, but if they're a person that are running off of a government phone who ran out of minutes, they're not being able to pick up. So I've seen all these issues that happen in the public health sector that aren't being addressed, that, the people who can make those kinds of decisions to help those kind of situations is way above me. But now I feel like I'm actually doing something, though.
Wow.
I'm going out and helping them where they're at.
Well, so I'm just thinking about your scale. So obviously my assumption is you both, Monica and Dominic, are thinking about how do we build this thing one time for many? And you're going down the path now of building that framework to facilitate doing that. So maybe can you speak a little more to the challenges there? And then I'm wondering, is it going to scale in Cobb County? Can it scale in Cobb County, then to the state? Can talk through what that looks like, please.
I think it can. Some of the terms we've had focus groups and interviews for years now with a variety of people in this space: psychologists, firefighters, police, social workers, licensed professional counselors. We had a psychiatric pharmacist.
Fascinating. Yeah.
It's fascinating because and the pharmacist is a good example. There are names for drugs on the street, but they're also the pharmacological name. And so we built up that taxonomy, and that pharmacist knew certain drugs, if you skip one dose, you have a chance of having a real issue, mental health breakdown.
Well, and how in the world do you capture that into something machine readable out of, wow, that's complex.
So then that gets processed through the scanning, the natural language processing, to say if that word shows up or a related word in one of these reports, we need to extra flag that one. You see what I'm saying?
Yeah, I do, and that's a lot of work.
It's a lot of work,
and there's going to be a lot of gaps. And
there's a lot of gaps. And actually, because there are gaps, one of the forefronts of AI is what we call active learning and attention mechanisms. And so the attention mechanism is related to what I just mentioned, but the active learning is if, say, Matt's looking at cases, if Jacob's looking at cases, and we give them a button that says this one really was not important, we feed that back in to retrain the model to say, pay less attention to that. And that allows it to actually become suited to the local situation as the local situation changes, because we cannot say that what we create today is going to be good forever. Right. It's got to evolve with the new names of drugs on the street, with the new behaviors people are getting. Anxiety is through the roof right now. I know that as a professor. I see students all the time. Anxiety was not through the roof 10 years ago. We had opioids and things like that. Things have changed. Like we've got a different sort of, cases are changing.
Right.
In simple English, for me, I would say what this has done for KSU students, particularly my social work students, now understand their role in helping to design mental health AI, which is something they had not thought about.
That's right, and they have to.
And that's a new profession for social workers, is if we are not involved in designing AI and just focus on large data, doing the diagnosis on its own, without what they call human in the loop element, it'll be fraught with errors and biases. Right? So we are changing that thought process at Kennesaw with the student. These are normal challenges because the ecosystem is not there.
Well, that's right.
But the universal design the architecture of what we are building, it's universal architecture, that once we deploy it with Cobb, right, and they authenticate the accuracy, the nature of the solution is scalable because I have conversations across Georgia. Counties are reaching out to us and saying, Cobb leads. And I say Cobb leads because Cobb first responders, whether it's fire, EMT, Valsta, I want to say big kudos to Valsta Community Health, where Valsta Find Help is situated. Kudos to them. They all want to play ball with each other.
Right.
They are willing to have conversations. Our county commissioner, chairwoman Cupid, she's a trailblazer in this space, right? There's a lot of leadership at Cobb that is saying we want to collaborate to solve. I think that makes everything possible.
That is the key. Absolutely.
I just want to thank you both. I mean, you're showing a side that I think most in society don't realize. People care. Thank you all for being here. And thank you both again for your service. And Monica and Dominic, thank you guys for what you do.
Thank you.
Yes, absolutely. My pleasure.
Thank you.